Before we start, this video examines in-depth topics of body image and eating disorders. If you don't feel comfortable with a discussion of these topics, I would suggest coming back another time. I've provided resources in the description and throughout the video to help anyone struggling with these issues. Hello parent, friend, athlete, coach, or anyone in between. This video is about a topic that's become very dear to me. High school distance running is a culture that I'll always treasure, but it's something that I'm barely able to do. My name is Ty, and as of writing this, I'm a junior in high school. Since I started high school, I've participated in some capacity in our distance running team year-round through summer training, cross-country, indoor track, and outdoor track. I will immediately preface this video by saying that I don't have an eating disorder. However, I do have a condition that makes it very hard for me to eat enough to fuel my body. This results in my accrual of a ton of injuries that have severely restricted my physical activity and namely taken me away from my love for running. However, while I will use my own experiences to illustrate certain points, this video won't be about me, but I say this to show how I've gained an interest in the topic of eating disorders as they relate to running. My nutritional deficiency made me think a lot more about other sources of nutritional deficiencies in running, and the one that obviously comes to mind is the prevalence of eating disorders in this sport. I also think that my perspective as a high school athlete should be valuable in addressing problems with adolescent distance running, as I've obviously had a lot of first-hand experience with it. Throughout this video, I'll cover why eating disorders are so prevalent in distance running, their consequences, why people develop them, why they maintain them, why they're hard to report and to treat, and what I think are the best measures to solve the problem. This video will be comprehensive, but I think everything I'm about to say is important. If such a long video seems intimidating or too time-consuming, I will link another condensed version of this video in the description. I've also outlined chapters and sections of this video in the description for ease of navigation. Without further ado, here's a comprehensive review of eating disorders in high school distance running. To begin, what is an eating disorder? Eating disorders are excessive and harmful disruptions in eating behavior, and are generally characterized by extreme concern with body weight. This definition encompasses a variety of disorders, but for the purposes of this video, I'm just going to focus on the ones most relevant to distance running. The first, and most well-known, is anorexia nervosa. It's usually characterized by intense fears of food and weight gain and severe restrictive behaviors. Secondly, there's bulimia nervosa. Bulimia nervosa is typically defined by instinctive cycles of binge eating and subsequent compensatory measures intended to offset food consumed, which can take various forms. One lesser-known eating disorder is ARFID, or avoidant restrictive food intake disorder. ARFID is very different from the eating disorders I've covered so far because it isn't associated with a fear of gaining weight. Individuals with ARFID undereat because they're essentially very picky eaters, driven by extreme revulsion to certain tastes, smells, textures, or colors. ARFID may also be driven by a general disinterest in eating, where it feels like a chore and is thus often shirked as one. Finally, OSFED, or other specific feeding and eating disorder, is an umbrella term to describe a bunch of other more niche or unnamed disorders. One such disorder is orthorexia nervosa, which is characterized by obsessing over food groups and cutting out foods deemed impure. However, the most critical thing to remember is not the criteria for each eating disorder, but rather their fluidity. For example, anorexia and bulimia have significant crossover. Individuals with anorexia may present binging and purging behaviors, and individuals with bulimia may present dangerously low levels of body weight. Thus, diagnoses are usually based on which one the individual fits better. Diagnoses are ultimately inventions designed to clarify and concisely name conditions for the purposes of organization and standardization, but obviously human minds and bodies don't follow our arbitrary clinical rules. Any individual's eating disorder is infinitely more complicated than its two-word designation, so it's more important to understand eating disorders as a whole than to memorize each type. This doesn't mean that diagnoses aren't important though, and it especially doesn't mean that anyone should attempt to diagnose themselves. Diagnoses are still vital for identification and recognition of an eating disorder, and if you feel that you align with the symptomatology of one, please consult a professional. I've linked a few resources in the description for anyone unsure of how to get started. To build the framework for the consequences of eating disorders, I'll start by introducing the concept of relative energy deficiency in sport, or REDS. REDS describes the variety of impaired functions caused by low energy availability in athletes. These impaired functions may include harmful abnormalities in bone health, cardiovascular function, mental health, and reproductive function. Of course, if any of these things aren't working correctly, athletic performance will inexorably fall with them. Energy availability consists of two parts: energy intake and energy expenditure. Energy intake is the energy from the food you eat, and energy expenditure is the energy you spend to perform certain functions. Too little energy intake, too much energy expenditure, or a combination of the two can cause low energy availability and the symptoms delineated by the REDS model. Consequently, because adolescent athletes must meet the intensive growth demands of their body while maintaining training requirements, they're at a heightened risk for low energy availability. To illustrate this concept of REDS, I'll use myself as an example. For me, REDS manifested as numerous chronic joint, bone, and tendon injuries, ones that I've been unable to recover from for years, despite considerable effort through conventional methods like physical therapy. My low energy availability stems primarily from the low energy intake part. Simply put, I have a condition that causes me to get full and feel nauseated really easily, meaning that I struggle to eat enough to properly fuel my body, or, in other words, achieve adequate energy intake. Thus, my energy expenditure outweighs my energy intake, and I end up low in energy availability, causing REDS symptoms. Like me, you don't have to have an eating disorder to have REDS, but it's not hard to see how eating disorders are heavily associated with low energy availability and REDS. Eating disorders generally drastically decrease energy intake and will occasionally overload energy expenditure, leading to low energy availability and REDS symptoms for athletes. With this understanding of energy availability, the next section will focus on the specific and most important repercussions of eating disorders, as well as provide an understanding of how exactly nutritional deficits cause these repercussions. So, what exactly are REDS symptoms, and how are they caused by a nutrient deficit? Let's start with just the physical. Obviously, your body needs energy from food to function. If your body is not receiving as much energy as it's expending, it begins to prioritize vital systems, meaning that other, still important systems in your body don't receive the nutrients they need. Of these systems, one of the most notable is the endocrine system, which regulates hormones. This dysfunction in hormone regulation is commonly observed in women as the loss of a regular period. Men lack such a distinct symptom, but general decreases in sex drive can be a good parallel. Though, while issues themselves, in this case loss of a regular period and reductions in sex drive serve as indicators of a greater issue: deteriorating bone health. Osteoporosis is a condition characterized by low bone density, and osteopenia is the same thing, just less severe. Both conditions are commonly hereditary, but are strongly linked to eating disorders through REDS. This link is for two reasons. One, that nutrients themselves are important for building bones through proteins, vitamins, and calcium. And two, that hormones directly regulate bone remodeling. For the former, proteins in the form of collagen compose bones, so protein consumption is obviously important for bone health. Then, put simply, vitamins have a variety of positive effects on various functions that interrelate with bone health. Finally, calcium composes an essential element of bone structure. However, the latter, hormonal reason, is less direct. As I said, loss of a regular period and reductions in sex drive serve as indicators of hormone dysfunction. And, in very simple terms, hormones are key regulators of bone remodeling, which is an essential process for skeletal system health and strength. These two elements illustrate how nutritional deficits lower bone mineral density, which has been directly linked to higher rates of fractures. Furthermore, since much of bone development is completed during adolescence, early problems with bone health can persist indefinitely and incurably. All of this means that eating disorders are catastrophic for bone health because of the nutritional deficits they entail. This is especially concerning for adolescent distance runners who are currently developing their bones and frequently using them to run. As any distance runner knows, injuries, especially chronic bone ones, will devastate races, holistic performance, or even entire seasons. And that's just one of the most pressing physical consequences for athletes. Feelings of weakness and fatigue are extremely common, as are specific symptoms like feeling cold all the time, decreased heart rate, blood conditions like anemia, and increased susceptibility to illness. Many of these symptoms obviously result from a lack of energy, while others are a product of the body's decreased metabolism as it tries to adapt. Furthermore, through chronic starvation, the body is also put in a never-ending state of fight or flight. This results in chronic elevation of stress hormones with various downstream consequences, both physical and mental. Finally, eating disorders result in real neurological changes that directly disrupt decision-making around food. It's easy to assume that eating disorders are driven primarily by a lack of understanding, but the reality is that most people with eating disorders logically know what they should or shouldn't be doing, but their reward systems and decision-making processes that dictate what they actually do are physically, neurologically disrupted. We've still only covered the physical symptoms, though. The mental strain that comes with an eating disorder is equally as important on its own and through its interrelation with physical symptoms. Variance in mental symptomatology is very high, so not everything I list applies to everyone with an eating disorder, but these are some of the most recurrent and salient consequences that I've observed. For one, stress and obsession over routines can crowd out other thoughts and functions and result in devastating feelings of failure upon deviation from the routine. Social isolation can result from avoiding events with food, a loss of energy to commit to relationships, and reducing previously fun activities like exercise to compensatory measures. Low self-esteem, a distorted self-image, constant self-criticism, and obsessing over flaws. Significant conflict between rational and irrational thinking, which may reflect the disruption in decision-making I outlined in the physical section. Finally, there are generally heightened rates of other psychiatric disorders like depression and anxiety amongst individuals with eating disorders. Many of these could deserve deeper dives on their own, but I think that's outside the scope of this video given my focus on distance running. The important thing to know is that having an eating disorder can be extremely isolating and exhausting. Aside from the prominent baseline suffering, this can also take focus away from other priorities, further negatively impacting general quality of life. To summarize this section, eating disorders are extremely dangerous psychiatric conditions that manifest as a variety of debilitating physical and mental symptoms. One of the most pertinent to specifically distance running is the inhibition of proper bone development, increasing risks for fractures that disrupt training and halt progress. With everything I've outlined thus far, why would anyone develop or maintain an eating disorder? Unfortunately, it's usually not as simple as just wanting to be thin. I'll start with the influences that don't pertain specifically to athletics. Once again, these will be summarily covered to establish a background, and I'll dive deeper into influences specific to distance running afterwards. Despite the glaring physiological and psychological consequences, the most famous and common motivation is the fear of gaining weight. Another well-known one is a desire for control, oftentimes resulting in or caused by perfectionist tendencies. This desire is then fulfilled by the individual's belief that they can control their weight and hunger. Other motivations include positive reinforcement from peers about thinness, coping mechanisms for emotional triggers, or a desire for structure. Once again, though, the most important thing is to recognize that eating disorders can stem from a myriad of stressors, and reducing them to one single cause can be ignorant and destructive. For example, some people not motivated by control are frustrated by the assumption that everyone with an eating disorder is. So, I'd like you to keep in mind that these motivations can overlap and intertwine, and that not all of them are applicable to everyone. With that in mind, let's look more closely at motivations prevalent in specifically distance running. Along with other lean-focused sports, distance running presents significantly heightened levels of disordered eating behaviors. Despite weight loss efforts undermining strength, recovery, and overall health, a frequent assumption about running is that weighing less automatically improves endurance performance. However, it can be hard to look past that doctrine of weigh less, run faster, largely because of its appeal through simplicity. This results in the pervasion of thin ideologies amongst runners, infecting team culture and becoming a core tenet of distance running dogma. This means that teammates might compliment one another for looking so thin or so healthy, or falsely assert that they'll run so much better because of their weight loss. Thus, misconceived gains in performance may define a lot of the motivation for dieting in distance runners. Attempting to radically chase this ideal of thinness is extremely unhealthy and detrimental to performance. Our bodies are all different, and what may be someone else's fastest, healthiest weight is just not applicable to another different person. Ultimately, the fastest and most sustainable that anyone will run will be when they're at their healthiest. This idealization of thinness manifests as a variety of pressures that surround young athletes to lose weight. Unfortunately, I don't think I can dive very deep into this because there aren't many objective analyses of weight pressures in distance runners. Metrics and questionnaires have been developed, but I can't find them being applied to specifically runners. However, significant pressures in other sports that emphasize weight, like gymnastics, have been demonstrated. Negative comments from coaches, their facilitation of unhealthy eating practices, and precipitous desires for weight loss amongst athletes are all prevalent themes. While I can't say in good faith that these things are all applicable to running, I think it does provide a good foundational understanding of an environment with high pressures around weight. The literature also readily supports prevalence of coach and teammate weight pressures in sports as a whole. In regard to coaching pressures in running, though, there is one very famous and stark case study in Mary Cain. In a story published to the New York Times, Mary Cain recounts how she was on top of the high school running world and eager to become one of the best female athletes of all time. This wasn't a pipe dream for her either. She set national and world high school and junior records, even representing the United States at a world championships before graduating high school. She was so good, in fact, that she was able to become a professional runner for Nike at the age of just 17. Unfortunately, this decision would end up disastrous for her. She was met with an all-male Nike staff, many of whom were not formally qualified, with no certified sports psychologist or dietitian, headed by the now infamous coach, Alberto Salazar. Alberto was obsessed with Mary's weight, convinced that losing weight was by far the best way to make her faster. Of course, his hand-picked team of his friends was not going to disagree with him, and it's not like they had the credentials to properly help Mary anyway. Naturally, this made her feel very trapped and alone. She had nobody who recognized that she needed help, nobody willing to help her, and an oppressive team of staff that reduced her to numbers on a scale. She says that she won or lost races not by her performance, motivation, discipline, or fitness, but by how close she was to Alberto's arbitrary number of pounds. She ended up losing her period and breaking multiple bones. And after what she describes as a metaphorical kick in the head, she finally reached out to her parents, who were naturally horrified and helped her leave immediately. Her experience serves as a frightening example of coaching malpractice in regard to healthy eating, illustrating how coaches might serve to bring about eating disorders. I won't argue that this applies to every one of or the majority of coaches, given that her story is still only singular evidence. However, I do think that such an appalling example, combined with the prevalence of coaching pressures in sports that emphasize leanness, makes a good argument for concern in distance running too. Aside from coaching pressures, families with inaccurate perceptions of healthy eating can induce disordered eating behaviors, and peers play a huge role in pervading the thin ideal in distance running. Parents are obviously in perhaps the most important position to influence younger children, and many personal accounts of weight loss for athletics support the eminence of domestic pressures. Yet, peer pressure remains one of the most concerning parts of disordered eating promotion. Especially as teenagers, we are subject to considerable social influences from other adolescents. This means that criticism and opinions of our peers will be especially incisive in regard to forming our internal ideals. In distance running, this manifests as a significant pervasion of the thin ideal, through its common acceptance and pursuance, and even through jocular banter between teammates. In general, teenagers are very susceptible to body image cues from their peers, in person or from social media. Once again, I wasn't able to find scoping empirical analyses of peer-to-peer pressures, but as a teenager who's been very present in distance running spheres, I can absolutely attest to the prevalence of pursuing and encouraging thin ideology, even if in joking manners through banter, which has still been shown to be harmful. I mentioned social media too. Obviously, an important facet of modern teenage life, social media gives a huge platform to perfectionism and unhealthy eating patterns from oftentimes entirely disreputable sources. Combining unhealthy food cues with idealized body images via trends like "what I eat in a day" videos can inculcate a toxic perception of body image in teenagers, who are the primary demographic of these videos. Online bullying via comments sections and promotion of so-called detox diets can also be very damaging to teenage perceptions. These impacts are very general. You'll notice that I'm referring to teenagers as a whole. However, it's highly likely that these influences will be more readily accepted by distance runners who are already engaged in a culture that tirelessly vaunts thinness. Our peer-to-peer interactions and constant bombardment with self-proclaimed health experts on social media promoting their inimical, misleading, and overly general health advice to young athletes can support a teenage culture underlain with noxious yet enticing falsehoods. Thus far, I've avoided separating eating disorders on the basis of sex. While eating disorders are much more commonly accepted and realized for females, and truthfully disproportionately affect them, males make up no small portion of eating disorder cases, and it would be wrong to alienate them. However, this section will focus on one potential allure of undereating for specifically girls in distance running. Before puberty, performance metrics between girls and boys are actually quite similar, and the biological gap tends to manifest during and after puberty. Boys tend to gain more muscle mass during puberty because of increasing testosterone levels, while girls lack such a drastic increase. This means that boys gain a huge distance running performance advantage from puberty, and girls tend to plateau more due to growing bodies without a large muscle mass gain. To be clear, puberty is a healthy and necessary part of growing. Attempting to prevent it will inevitably result adversely for overall health. Furthermore, the muscle mass increases that girls do experience during puberty, and the increased bone integrity from rising estrogen levels will, in the long term, increase performance. So, not only is a generally healthy body obviously vital for athletic function, but the resultant mature body from puberty will fare better than a prepubescent one, just maybe not instantly. However, this disclaimer is never made clear enough to many female athletes who realize puberty may initially hamper them and instead attempt to stave it off in an effort to retain their smaller, immature forms. To illustrate this point, I'll introduce another case study, Allie Ostrander. Allie Ostrander, like Mary Cain, was another high school distance running phenom. In her senior year of high school, she won Nike Cross Nationals, and in college went on to place consistently high NCAA Division I meets across track and cross country. She forewent her final year of collegiate running to run professionally, where she competed across multiple world championships and even in the Olympic trials. In one of the most widespread videos on this topic, she speaks about her long-term experience with an eating disorder. Allie displayed many of the hallmarks for eating disorders that we've reviewed so far: perfectionist tendencies, size encouragement from running media, internalized avoidance of food, desire for control, being uninformed about healthy eating practices, as well as stating that she was directly discouraged by adults in her life from hitting puberty, through their misguided remarks that it would slow her down. Thus, she attempted to delay puberty by not eating enough. She began displaying many of the physical symptoms of an eating disorder, like losing her period, feeling cold all the time, and anemia. She says that she was terrified of growing and slowing down, and was indirectly encouraged by those around her. Most girls attempting this will incur severe consequences rather quickly, but she ran with her eating disorder through high school, college, and the beginnings of her professional career before its consequences finally caught up with her and she was forced to address it. During this time, she suffered many bone stress injuries, among numerous other impairments, which significantly impacted her mental health as an elite runner who relied on her ability to, run. She says that she wishes she was educated on the necessity of puberty for female athletes, instead of having it demonized as a performance killer. She also contends that healthy progression for female athletes consists of a plateau in high school that later yields performance increases in professional and collegiate careers. This seems to be supported too, though not definitively. For example, one analysis by MileSplit, averaging the performance of the top 100 cross-country girls for grades 7 through 12, demonstrated significant ups and downs, contrasting the linearity of the boys' times with the same parameters. This isn't a peer-reviewed scientific article, so I'm hesitant to promote it as empirical evidence, but it does align with what one would expect given what we've learned so far. Boys tend to glean significant performance improvements from rising testosterone levels, while girls are more balanced. Thus, one would expect a somewhat linear progression for boys and a more unstable one for girls. To summarize this section, despite the reality of puberty being a necessary biological process for long-term and sustained success, prospective distance running girls may be encouraged to develop disordered eating behaviors through a fear of puberty because of uncertainties around future performance. Finally, ending this story more positively, despite Allie's struggles, she continues to run semi-professionally and post on her YouTube channel. While devastating, the effects of her eating disorder haven't managed to destroy her love for running. Cain has also since used her experience to provide all the support she lacked as a female athlete to as many girls as she can. To conclude this whole part of the video, I hope that these examples have made clear the variety of pressures that encourage disordered eating behaviors in adolescent distance runners. Aside from general influences, distance running can especially encourage eating disorders through sometimes misinformed coaches, misguided teammates, and unqualified social media influencers, fears and uncertainties around puberty for girls, and a fundamental misunderstanding of what running, being a lean sport, even means. These motivations and encouragements can ultimately amalgamate to shape the individual's identity around being thin, supposedly healthy, fit, or having control, meaning that the problem transcends from a physical disorder to a core psychological cast. Despite their devastating effects, sometimes eating disorders can be all too enticing. Before we can dive into solutions, we still have to understand why seeking treatment can be difficult for many individuals with eating disorders. It's not as simple as noticing a cut and getting a band-aid, so no discussion of solutions would be complete without a fundamental understanding of how to make them accessible. Furthermore, I'll split this section into two parts. Firstly, barriers of recognition to an eating disorder, and second, barriers to seeking treatment post-recognition. Many people who meet the criteria for an eating disorder don't actually recognize it in themselves. Once again, reasons for this lack of recognition can be extremely variable, so I'll propose three main drivers. Firstly, a lack of education. An alarming number of survey subjects are not properly able to identify an eating disorder, which could extend to not being able to identify them even when they have one. For example, one may justify disordered eating habits as a crucial part of athleticism, or believe they're a truly healthy form of dieting. But a lack of education can also manifest externally, where, for example, the individual's friends react apathetically to their problems, or even healthcare professionals are dismissive because they just aren't aware of what is and isn't problematic. Another main motivator could be the comparative minimization of one's problems, where individuals don't believe that they're sick enough, that their eating habits are just mildly troubling, and nothing in comparison to the horror stories they might have heard. They can even be spurred on by external critiques, sometimes causing further determination to become sick enough and delusionally prove capability or strength. In a similar vein, for athletics, individuals may not be receptive to cautionary tales like that of Cain and Allie Ostrander because they might not be at that elite athletic level, and thus believe the dangers can't possibly apply to them. This seems to be an extension of a lack of education on both internal and external parts, but I've seen it enough on its own that I think it deserves its own mention. Finally, individuals may be actively unwilling to acknowledge their eating patterns as problematic because of shame at having a problem in the first place. This could be because the individual's eating disorder centers around control, and admittance of a problem may represent a loss of control, a shame. Underlying behavioral patterns of self-reliance could also dissuade individuals from admitting their problem because they fear admitting to their weakness of succumbing to something. Finally, men with eating disorders may be especially unlikely to recognize them because of their popular designation as a woman's problem, and therefore making men feel emasculated by admission. Lastly, I think that in high school, and in distance running especially, a lot of these problems I just discussed may be exacerbated by our mass adoption of restrictive eating behaviors, effectively normalizing them. Unhealthy and restrictive eating habits have been shown to spread through high schoolers, and as a student myself, I've seen this effect in real time. Especially for people who are not noticeably thin, disordered eating behaviors may be even more unlikely to be recognized, and often encouraged. These factors contribute to the lack of education part, because everyone believes restrictive eating is normal and healthy. They contribute to the not sick enough part, because the individual is surrounded by people supposedly sicker than them. And it finally contributes to shame, because one would have to admit not being able to handle something that everyone else apparently is. I simply can't envision any of the three drivers I proposed being easy to work through in such a toxic eating culture as high school distance running, or even high school in general. Let's move on, though. Even once an eating disorder is internally recognized, seeking treatment can still be another ordeal. Around 2/3 of individuals with eating disorders do not seek or receive help. This can be due to factors we've already discussed, like the individual's belief that they aren't sick enough to deserve treatment, under-recognition of eating disorders by physicians, fear of losing control, shame, or any other litany of reasons. A few additional barriers to specifically seeking help are not knowing what to expect from a visit, long wait times for treatment, and difficulties affording treatment. On average, doctors are usually woefully uneducated in eating disorders because they don't receive sufficient education on them. This means that doctors are less likely to accurately diagnose eating disorders, accept their presence, or refer a patient for secondary care. The majority don't even believe that their education has accurately prepared them to address eating disorders. This can make obtaining treatment from the few people who are supposed to supply it difficult. Additionally, psychiatric disorders in general can be very hard to obtain treatment for. Some individuals may prefer avoiding negative emotions to confronting them. Some believe they can endure without professional intervention. Some fear negative interactions with mental health professionals. Time can be a constraint for busier individuals, and stigma around mental health is still ever present. These overarching problems with mental health treatment, combined with the barriers specific to eating disorders, present a difficult road for obtaining treatment. For any curious or wanting, I've provided a collection of resources in the description of this video to help with seeking treatment. All in all, there are many barriers to self-recognition of an eating disorder, and even more for obtaining subsequent treatment. It's really not as easy as recognizing a problem and deciding to do something about it. There are so many hurdles to overcome due to a paucity of accurate information and antagonistic cultures of stigma and shame. Now, I think we have the foundation to move on to solutions to disordered eating. I'll start with solutions and treatments for already existing eating disorders, and then move on to preventive ones. Post-development solutions are unfortunately sobering. The effects of osteoporosis in individuals with eating disorders are often permanent. Even typical treatments like estrogen therapy that work for other causes, like menopause, don't achieve the same success. Osteopenia can be reversed in adolescence, but not easily. Furthermore, prognoses are variable for each eating disorder, with around half of individuals with anorexia recovering in a decade, and the majority of individuals with bulimia recovering in the same time period. These recovery rates are rather bleak, illustrating how difficult it can be. This difficulty in recovery may be largely attributable to how the individual's holistic identity becomes formed around their eating disorder, meaning that recovery sometimes necessitates a total permutation of identity. Obviously, not an easy task. But thankfully, we have tools for such a task. The current foremost method is cognitive behavioral therapy, or CBT. CBT targets the psychological drivers that maintain disordered eating behaviors, aiming to replace them with positive behaviors. It achieves this through challenging negative thinking patterns by promoting mindfulness and awareness, helping the individual recognize distorted thinking patterns and giving them strategies for self-regulation. Ultimately, CBT seeks to equip the individual with a framework and an understanding to be their own therapist. Unlike CBT and other behavioral therapies I'll cover, many traditional methods of therapy may promote a sort of condescension, where professionals seek only to excise the problem in a very impersonal way rather than change the individual's relationship with it. I've undergone CBT unrelated to any eating disorder, but it's been very helpful for me through providing me with a framework I can use to adapt and reinforce positive and productive ways of thinking. Another significantly supported modality of therapy for eating disorders is family-based therapy, or FBT. FBT hinges on the parent's potential control of their child's eating behaviors. Obviously, many families eat at least dinner together, so FBT frequently enlists the parents and other members of the family to ensure that the afflicted individual eats a healthy meal during that time. Another component could be something like removing access to a scale, something shown to stem many disordered eating behaviors, as one would expect, or requiring blind weighing if weight metrics are absolutely needed for clinical purposes. Overall, FBT recognizes the disrupted decision-making processes in individuals with eating disorders, and thus temporarily removes the individual's ability to make those decisions about eating, instead giving them to the parents. Responsibility will then be gradually afforded to the individual again, until recovery is achieved. As one would imagine, this forceful kind of method can generate significant conflict between the individual and their family, leading to a relatively high dropout rate. However, its efficacy is self-evident, and I think that in conjunction with other proven methods like CBT, these approaches are very promising. Two other methods are dialectical behavioral therapy, or DBT, and acceptance and commitment therapy, or ACT. DBT is an approach that focuses on helping the patient with emotional regulation, mindfulness, and distress tolerance. For eating disorders, these skills lay the groundwork for successful treatment through thoughtful change on the part of the individual. ACT is an approach that, in contrast to CBT, encourages acceptance of negative thoughts without judgment, teaching patients to observe themselves simply and calmly. This sort of mindfulness practice, like DBT, lays the groundwork for further improvement in eating disorder cases because it allows for stronger and more lucid self-evaluations of behavior. All of these strategies exemplify that the most consistently effective strategies of treatment for eating disorders may not be combative and abrasive ones, but instead, treatments that give the individual a framework for reconciling internal struggles in healthy ways on their own. To conclude this section, I think that any approach to helping someone with an eating disorder, whether between the person and their coach, friend, teammate, family member, or otherwise, could benefit from the recognition that they're not simply behaviors to be corrected. Unfortunately, most problems can't be solved by just telling someone to do or to not do something. Just being there and offering empathetic support is essential, and it's important to recognize that resolving an eating disorder is a journey of identity. Before we move on to preventive solutions, I'd first like to clarify a big part of what healthy eating is. There are a lot of content creators, attractive ads, instant remedies, and pseudoscientific articles online that advertise themselves as undiscovered bastions of health. A common trend amongst these sources is claiming absolutes, where their advice is meant to be the best for every person regardless of circumstance. The reality is the opposite, where nutrition should be strictly individualized and guided by professionals if changes are necessary. I'll use myself as an example. If you remember, I have REDS because I cannot match my energy expenditure with the food I eat, because I have a physical condition that makes me get full very easily. So, part of my dietitian's solution to this was having me eat ice cream. Ice cream is definitely not something stereotypically viewed as healthy, but for me, it really was, due to its high caloric density, something that I desperately needed. What's healthy for any given person is extremely variable, and based on their unique needs. No food is outright good or bad, healthy or unhealthy. Everything is relative to the individual. Professional guidance is essential for addressing these nuances in lieu of overly general resources. Alright, as with any recursive problem, methods of prevention are going to be best. Nipping an issue in the bud will always be better than attempting to address its consequences again and again. With that said, this section is unfortunately going to be another tenuous one. There simply aren't that many empirically proven methods to prevent the manifestation of eating disorders. One such attempt is through education programs for schools, which have been recognized as an important setting due to adolescence being a critical time for eating disorder development. Unfortunately, as I previously said, many of the methods attempted have not yielded significant results, especially long-term and especially in younger age groups. One study I examined presents a notably successful program named MyStep that demonstrated statistically significant results in a mean age group of 13 and after 12 months. Many other programs may be initially successful, but falter after time has passed. So even though MyStep's efficacy was reduced after 12 months, its persistence at all remains an outlier from what I've seen. I bring this up to show that despite a rather grim portrayal of these education programs for schools, they can be effective, and that further attempts to make these programs refined and impactful may prove very beneficial. In regard to distance running specifically, I've come to believe that the best preventive methods are ones that revolve around generating awareness. Again, I unfortunately can't say that these approaches have been empirically tested, but based on the evidence we've examined so far, my own experiences, and the professionals I've had review this video, I'm fairly confident in what I'm about to present to you. I think that an approach to awareness can be threefold. First, coaches. Because coaches play such a key role in defining team culture around body ideals, they can be the foremost sources of healthy team norms by frequently promoting practices of healthy eating and being attentive to signs of disordered eating. Looking out for athlete welfare is already an essential part of a coach's job, and it usually starts with inquiring about food, hydration, and sleep in response to signs like dizziness, fatigue, or clumsiness. However, when these patterns become sustained, coaches can shift the conversation. They don't have to diagnose eating disorders, and they shouldn't, but asking simple questions like how's fueling been going, and pointing out these sustained patterns can open a space for athletes to share and be connected to qualified help. Furthermore, many coaches of distance runners must manage large teams, especially for sports like cross-country, and can't notice everything themselves. Thus, Creating a network between athletic trainers, assistant coaches, and team captains is essential for fostering the care that I just described. Treating eating disorders like other injuries and afflictions would be, where one is unable to participate in a sport unless they can provide proof of health, may also be meritorious in terms of promoting recognition of eating disorders as destructive factors that must be addressed. Alternatively, this could foster further motivation for hiding an eating disorder, so I won't fully endorse it. However, we can't get to this point if coaches remain uneducated and unaware of disordered eating habits. Right now, many coaches have no greater ability to recognize unhealthy eating behaviors than the general population, and many are apprehensive about approaching these topics with their athletes because they aren't confident in their own knowledge. Furthermore, education programs for willing coaches have been shown to be effective in ameliorating this issue, demonstrating how there is significant capacity for facile improvement in coach awareness. Coaches being able to not only teach their athletes tenets of healthy eating, but also identify symptoms of REDs and disordered eating in them can drastically improve team culture around eating and reduce the risk of an eating disorder going unnoticed. Secondly, parents. We've examined how parents influence their children's eating habits, and how they can play a role in cultivating unhealthy ones. Thus, if parents are made aware of their influence and potential faults in their doctrine, we may be able to foster healthier relationships with food at home, one of the most key settings for adolescent development. And finally, athletes themselves. I think that the two prior categories will disseminate awareness into this category through their teachings, but peer-to-peer interactions are still incredibly important for bolstering awareness and promoting narratives around food, unhealthy or not. As a teenager myself, I believe that we respond best to our peers. And we've previously discussed how unhealthy eating habits can spread through high schoolers. I'm not sure the best way to go about spreading healthy awareness in this group, besides receiving it from coaches, but athletes definitely can influence team culture in a positive manner by questioning misinformation and discouraging negative body talk. Social media is especially malevolent in regard to eating, so counteracting the misinformation it spreads on a peer-to-peer level is very important. Many teams, despite distance running's individuality, also have team captains for the purpose of leadership and role modeling. These team captains can model healthy eating habits while still being prominent fixtures of team culture, separate from the adult leader role that a coach may fulfill. So, having these role models may offer a nuanced way of proliferating a healthy and responsive team culture around eating. For any team member, I think it's also key to discourage negative body talk in general. Even just banter, as we've covered, has a detrimental effect on body image perceptions. I feel that this one can be hard to do for teenagers especially, because we're submerged in a culture that lauds edgy efforts to break societal norms. And I can't say that that's always a bad thing, but I do think that it makes discouraging potentially harmful topics very difficult for fear that one may be perceived as lame or overly sensitive. However, based on what I've observed and what the limited research suggests, it could at least be beneficial for athletes to be more conscious of who their conversations can negatively affect, and to try to subtly steer discussions away from negative topics. This ties back to the team captain piece as well. Team captains might be in a greater position to call out misconceptions directly without risking their social standing. Education for any of these groups can occur through videos like this, or through presentations to teams, coaches, or parents by professionals like dietitians. Schools that have the resources to host experienced professionals can benefit greatly from their presence, not just in terms of education, but also having the professional to assess team culture and habits, conduct interviews, and periodically check up on the team. I know this sounds like a lot, but much of it can be done very unobtrusively, in a similar way that schools may incorporate athletic trainers. Short sessions, inquiries, and check-ins can go a long way. Presentations for coaches revolve mostly around what I've talked about so far. Parents can benefit from information on how their child should be fueling for their sport, and athletes themselves should be given accurate information on how to fuel to avoid REDs. If coaches or athletic trainers are provided with proper education, then they may also be the ones to lead these discussions and check-ins. This replacement of misinformation and inimical narratives with more positive and truthful information may offer a promising and clear direction for reducing the culture that encourages eating disorders. My hope is that, similarly to how every runner understands injuries like shin splints, if we can establish this new baseline amongst high school distance running, that it will become common knowledge integral to the sport itself, passed down between classes and generations of athletes. Well, I hope you're still with me after all of that. This topic has become such a passion of mine over the last year, and I'm so excited to finally be able to create this resource. Eating disorders are a huge problem in this sport that I love so much, but you, parent, coach, athlete, or friend can help to foster a community in which they are not. If you take away anything from this video, I hope it's that what you say and what you don't say can make all the difference in this issue. Choose to create a space that allows athletes to fully recognize themselves and their potential. If you're a parent, evaluate yourself and what you're encouraging in your child. If you're an athlete, what are you seeing around you and your team? What do you personally believe? If you're a coach, apply what you've learned to not only advise your athletes, but educate them and prevent the manifestation of unhealthy habits. Finally, thank you for your attention. I've linked my entire video script in the description, which will include a full list of sources along with extensive in-text citations for any curious. Goodbye now.